Now this video is going to be the video for the skull base and the neurosurgeons who need to learn how to approach skull base in a very proper manner, also to know the entire anatomy of the sinuses which deal with skull base anatomy. So this video is also for all those ENT surgeons who do not know how to perform a FESS surgery. And so in this video I'll be covering up all the basics, the surgical techniques, the difficulties that a surgeon faces in his or her surgery when the FESS surgery is concerned. Also, through this surgery, I'll show you how to approach the skull base on different aspects when you're dealing with different situations in your skull base career. So the very initial part is going to be the first step of the radiology. Now, whenever you're going to learn the anatomy of the sinuses, you need to have a CT scan. 0.5 to 1 mm should be the ideal thickness, not more than that, because there are few neurovascular structures that are so thin that if you order a 5 mm or a 3 mm scan, you can miss those vital neurovascular anatomy on the CT scan. So make sure you either order a 0.5, which is the best, or you can ideally it should be at least 1 mm thickness. Coronal, axial and sagittal, all three scans should be visualized at the same time through a 3D multiplanar reconstruction feature which you get on the DICOM app basically. So to begin with, the very first anatomy I'll be showing you is from the most anterior aspect of this patient. Now the patient details, this is a middle-aged female patient having right-sided nasal blockage, both sides, but basically more on the right side. So this patient was having allergic rhinitis as well, some tenderness on the maxillary sinus, on the frontal sinus area, which is a forehead basically above the eyebrow, and very mild on the right side anterior ethmoidal area, which is basically between the two eyes on the anterior aspect, much more on the right side. So I'm going to show you the basic anatomy of how you can identify the structures on the CT scan. Now the most anterior part, you can see that is the patient's frontal skin. Now that's the patient's frontal skin. As we keep on going behind, that's the patient's frontal bone. Then you can see that's the patient's right side frontal, that's the patient's left frontal, that's the brain, the frontal lobe of the brain you can see right there. So what you can see right now here is the right frontal of this patient is showing some kind of opacification, and that hence the patient was having right side frontal tenderness, eyebrow headache, that is basically supraorbital headache. So as we go behind, you can see the left side frontal is completely clear. So there's no need, absolutely no need to open up the patient's left frontal. We do have to open the patient's right though and clear the frontal sinus. We can give a thorough wash after having opened up the patient's frontal on the right side. So as we keep on going behind, so for a neurosurgeon and skull base surgeon, if there's a CSF leak, normally post-traumatic road traffic accidents, a lot of patients do present into casualty with severe depressed fractures on the skull, the forehead, the temple area, and within a few hours they start experiencing a gush of nasal fluid pouring out on bending forward. Whereas typical presentation the patients have in road traffic accidents, and then you get the CT scan done, the patient has got pneumocephalus all the way around. If it's too severe, it can lead to tension pneumocephalus, which is an emergency case where you have to do an open craniotomy, the burr hole technique, and drain the air from outside, external approach. But if you normally see a lot of fractures here. So this is the frontal sinus roof basically, that's the frontal sinus floor, and you can see that's the bone which separates the brain from the frontal sinus. So if you have a huge fracture on this particular segment, the patient can have meningocele, or the patient can sometimes have meningoencephalocele, and if there's a rupture in the dura and the arachnoid popping in the sinus, the patient can have a CSF leak and can pour down the natural drainage pathway. So as you keep going behind, see this was the most anterior part, right? So as you keep on going behind, you can see the frontal sinus is flowing posterior inferiorly, and the drainage of the frontal sinus is inferiorly. So when you go posteriorly, as you can see, I'm going here posteriorly, you can see an opening here. So as long as the floor, this is the frontal floor, that's the frontal beak, which you call that as, which is the thickest bone in this area, very strong bone. So you keep on going behind, you can see the moment this frontal floor disappears, that's the area of the frontal recess. So that is the natural drainage pathway for the frontal recess. So the CSF coming from here superiorly pours down into the frontal sinus and comes into the nasal cavity via the natural frontal recess drainage pathway. And as a result, the patient, if he's having a lot of nasal CSF rhinorrhea, the patient will definitely complain one-sided continuous secretion, watery secretion, mostly on bending forward. Or sometimes if it's frontal, it's not necessary that the patient has to bend. With gravity flow, the patient can have constant CSF leak from one side. So that is how the patients present to the OPD of ENT, basically, that they are having a lot of nasal rhinorrhea. And once you examine the patient's CT scan and with proper clinical history, you will definitely diagnose that as a CSF rhinorrhea. And then you plan the patient for a CSF leak repair. So what you can do is either go external approach, that is a transfrontal approach, or you can go transbasal approach, where the neurosurgeon can have a supraorbital craniotomy and can access the roof of the frontal sinus and can repair the frontal sinus leak, which is superior. If you're a skull-based surgeon, you can just go endonasal. What you can do is do a draft procedure and endonasally, along with external eyebrow approach. You can take an incision just below the eyebrow, which is a medial approach, or you can take an incision at the upper margin of the eyebrow and you can just open up the frontal sinus externally, drill a hole or a bigger opening externally, or you can just take a piece of bone, a beveled edged piece of bone out, and can have direct access to the frontal sinus with an endoscope. So you can use a combined endonasal with external approach, or you can go with a transbasal or a supraorbital craniotomy approach, basically. So that is how you can deal with a frontal sinus leak for a skull base or a neurosurgeon. So coming on to the sinus scan again, so this is a lot of collection. We need to drain the sinus of this patient. Now going behind, there's a very minimal issue on the patient's left frontal. No need to open that. It is not big of a deal here right now. So you can see that's the patient's right orbit here. That's the patient's left orbit here. Now what you can see, a new structure that is appearing on the scan is the patient's nasal bone. That's the nasal bone up here. That's the frontal beak. So frontal beak is basically nothing but the floor and the anterior inferior. Basically that's the floor of the frontal sinus in the center. That's the midline. And that is basically the frontal beak. So if you keep on going behind, you can see the nasal bone starts extending as the frontonasal process of the maxilla. That you have to keep in mind. This is no longer a nasal bone here, but this is a frontonasal process of maxilla. And further on behind, you can see that the maxillary sinus starts appearing on both sides, and you can see this is the ethmoid sinus along with the agonasi cells over here. So how to identify an agonasi cell? Now, why the agonasi cell carries so much of importance on the scan is because when you are approaching the patient's frontal sinus, the agonasi cell will decide whether or not the patient's frontal sinus is going to have a bigger opening to the frontal recess or not. Because more the agonasi is pneumatized, the smaller will be the opening of the frontal recess, because frontal recess is anteriorly bound by the agonasi cell. So bigger the agonasi cell, smaller will be the frontal recess opening. So we need to know the precise location of the agonasi cell so that we can approach the frontal sinus very easily without any damage or without any residual left over of the anterior ethmoids. So as you can see, I'm going quite anteriorly right now. the moment you start seeing the frontal process of the maxilla, the second landmark is the nasolacrimal duct or the lacrimal sac. So I need to localize. That's the lacrimal sac area right here. So that's the nasolacrimal sac right here, opening in the inferior meatus. So similarly, we can localize the nasolacrimal sac on the patient's right side. That's the nasolacrimal sac on the patient's right side. So two landmarks to identify the agonase cell is the first is the frontonasal process of the maxilla. Just keep on following the frontonasal process of the maxilla posteriorly. Superiorly, you'll get the agonase cell, which is right here. That's the agonase cell. And yeah, so this was the nasolacrimal sac. Second landmark is the nasolacrimal sac. So once you find the nasolacrimal sac, which is this as seen on the scan here, which is you can see opening up in the inferior meatus right there. So just follow the nasolacrimal sac, and exactly above that will be the agonase cell. So what you can see right here is the agonase cell, and you can see one more cell above the level of the agonase. So that could be Kuhn type 1 cell. So Kuhn's 1 and Kuhn's 2 is basically presence of excess cells above the agonase, but in the frontal recess. Kuhn's type 3 and Kuhn's type 4 is basically present in the frontal sinus. You have to remember this differentiation point. Kuhn's 1 and Kuhn's 2 is in frontal recess. Kuhn's 3 and Kuhn's 4 is in frontal sinus. So we've located the nasolacrimal sac and the duct, and exactly above that will be the agonase cell. I can somewhat see one more cell over here. So the agonase is kind of huge over here. A small cell, there's one more cell, could be Kuhn's type 1 as such. So coming more posteriorly, you can see the entire ethmoids, the anterior ethmoids is full of some soft tissue over here. So the maxilla is full of some kind of soft tissue. The anterior ethmoids is full of some soft tissue. So as we keep on going behind, you can start seeing the orbit here. So this is entirely brain, and that's the entire skull base that you can see. That is the only bone that separates the brain from the orbit and the sinonasal cavity. So if in case of a road traffic accident, the patient may also have a fracture segment in the cribriform area. Now I'll show you the cribriform in some time, but I'll show you the orbit first. Now this is the patient's right side orbit, that's the patient's left orbit. So what is the significance of the orbit for a skull base or a neurosurgeon? Now the neurosurgeons or the skull base surgeons can use the roof of the orbit as a landmark to guide him or herself towards the frontal lobe base. So if you're using a transorbital approach, where I've shown in my cadaver video, I have completely shown the basics of surgery, how to perform a transorbital surgery in a cadaver. So I've shown in that case, the transorbital approach can prove pretty useful for a skull base and a neurosurgeon. So you have to completely retract the eyeball down along with the periorbita, and you completely take the help of the roof of the orbit to either gain access into the cavernous sinus, which is transorbital, transcavernous approach to any tumor in the cavernous sinus, or you can have an approach to the ICA through the transorbital route, or you can also approach the Meckel's cave through the transorbital route. So in that condition, the roof of the orbit is completely important. You may have to drill the greater wing of sphenoid. The major part of the greater wing of sphenoid you may have to drill. So if you keep on going posteriorly, what you can see is that this is basically all greater wing of sphenoid to access the posterior most part of the frontal lobe and the temporal lobe as well. So transorbital, the orbit is completely important. You need to know the basics of how to approach the cavernous sinus, the Meckel's cave, and the temporal lobe along with the frontal lobe via the orbit. So coming more posteriorly, what you can see right now, so the orbit, right? Yeah, so this is the globe of the orbit, and as we keep on going behind, you can see some kind of this is the extraocular muscles, basically the superior rectus, the medial rectus, the inferior rectus, the lateral rectus, and you can see various muscles out there. So if you have to go endonasal, do an optic nerve decompression or orbital decompression, you need to know the precise anatomy of the medial wall of the orbit, that is the lamina papyracea. So you have to completely resect the lamina papyracea if you have to perform a orbital decompression. So I've posted a lot of videos of orbital decompression in my skull base and FESS Marathon 2023 series. I have a lot of videos of CSF leaks, skull base tumors, clival tumors, orbital and optic nerve decompressions, tumor compressing on the optic nerve, decompression of the optic nerve. All those videos you'll be able to find in the skull base and the FESS Marathon 2023 section. So you can see that's the medial rectus, that's the superior oblique, that's the globe, that's the superior rectus muscle over here, that's the lateral rectus, and the inferior rectus over here. The obliques, that's the superior oblique. So whenever there is a confluence, or whenever the medial rectus and the superior oblique muscle, they come together or in a very close confluence, you can see that's the anterior ethmoidal artery that is exiting right here. So there's some kind of nippling, that conical nippling that is happening over here. That is basically nothing but the exit of the anterior ethmoidal artery. You can see the same anterior ethmoidal artery on the left, and that is piercing the lateral lamella of the cribriform. So this is the anterior ethmoidal artery, travels from the orbit, which is a branch of the ophthalmic artery, the ophthalmic artery, which is in turn a branch of the internal carotid artery, the supraclinoidal segment of the ICA. So there are two branches that come from the ICA, supraclinoidal segment. That the very first branch will be the ophthalmic artery, and the second branch will be the superior hypophyseal artery, which supplies the optic nerve, the optic chiasm, the pituitary stalk, the pituitary gland as well. So this anterior ethmoidal artery travels from the orbit, enters the lateral lamella of cribriform, and then intracranially it gives off a branch called as the anterior falcine artery, which definitely supplies the falx cerebri and the dura, the meningeal layer in that particular area, in the frontal lobe area. So it comes back again to the dorsum of the nose, gives off branches along the superior border of the septum and midline, and eventually, it ends up in the dorsum of the nose. So that is how the anterior ethmoidal artery traverses. So you can see there's a lot of opacification near the area of the anterior ethmoidal artery as well. And this anterior ethmoidal artery, the space between the skull base over here and the anterior ethmoidal artery is hardly few millimeters. I would say 1 or 2 millimeters. So you need not worry. The anterior ethmoidal artery is not that low hanging in this case. So if you're doing the clearance in the anterior ethmoids area, you may not end up damaging the anterior ethmoidal artery so much as compared to when the anterior ethmoidal artery is very much hanging low. So that is basically the rough idea about the orbit basically. So as we keep on going behind, we keep going behind, we can see that the sinus is completely huge on the right side. So the right maxillary sinus is kind of very huge. I'll open the maxillary sinus with a 70-degree and a 0-degree endoscope inside. You can see there's a lot of inferior turbinate hypertrophy. There's some kind of deviation of the septum on the left side with the spur on the left. The ethmoids are also involved. Nothing major. The lamina papyracea looks thinned out probably over here. The skull base looks intact. There's no dehiscence or kind of any meningoencephalocele or meningocele in this patient. Just a routine case of right-sided FESS I'll be performing, but at the same time I'll be covering up each and every anatomy from a skull base perspective as well. I'll show you the anatomy of the anterior, posterior ethmoidal arteries. I'll show you the optic nerve. I'll show you the basic layout of the sphenoid sinus, how a skull base or a neurosurgeon approaches the pituitary gland for sellar and suprasellar lesions, how to use the medial approach to the sphenoid sinus very carefully, and how to differentiate between the actual sphenoid sinus opening and the false opening that leads into the Onodi cell or the posterior ethmoids. And that is how you can prevent the damage to the skull base from happening. So all these basic points I'll be showing you in this video. so that once you see this video, any neurosurgeon out there or a skull-based surgeon or a young ENT surgeon will definitely not have any neurovascular damage whatsoever. So going behind, you can see the orbit starts becoming more conical. So it was kind of circular initially. You can see it's more circular initially, like a rectangle circular, and then as we keep on going behind, it becomes more conical in shape. So it indicates that we are in the posterior ethmoid. You can see that's the huge maxillary sinus completely taken up by the soft tissue. As we keep on going behind, there's a huge opacification. You can see over here, almost the entire anterior and the posterior ethmoid is completely involved. Now, just look carefully on this frontal bone. Now, this entire bone is basically frontal bone. Now, this is a pterion point over here. Now, as we keep on going behind, at some point, this frontal bone will discontinue, and you can start seeing the temporal lobe of the brain. So once this frontal bone stops or disappears, that's the indication that at that particular point, the sphenoid sinus has started. That's the sphenoid sinus you can see right there. So as you keep on going behind, that's the actual sphenoid sinus, and the orbit will become more conical and the orbital apex will be approached. Okay, and that's the posterior most part of the maxillary sinus. You can see it's completely covered up with the soft tissue, as well as this patient's right sphenoid is completely covered up with soft tissue. So you can see that's the temporal lobe. As you keep on going behind, that's the optic nerve. You can see that's the anterior clinoid process. That's the anterior clinoid process right here. That's the lesser wing of sphenoid basically. That's the right sphenoid. But if you can see very closely, there's a oblique septa over here. Very carefully you can see here, that's an oblique bony septa, not very clearly seen. This is basically an intermediate soft tissue window, not an actual bony window, although this looks like a bony window, but this is basically an intermediate window as well. So hence, as a result, the bone is not that clear, but you can see a very soft partition over here. So what I can think of after having a look at this is that once you enter the sphenoid inside, probably you will be finding some kind of oblique crest septation dividing this area with this area. So we need to just have a proper look once we go inside. The entire right sphenoid is full of soft tissue. That's the optic nerve, you can see right there, medial to the anterior clinoid. And the further we go behind, that would be the cavernous sinus along with the ICA. The left sphenoid is completely fine. You can see as a result, we don't need to go on the left side. You can see some kind of secretions in the corona on both sides. Somewhat maxilla is also involved in the patient's left. So that's the inferior orbital fissure. You can see in the inferior aspect of the orbit. Then, so one more important point is that as we keep on approaching the sphenoid in the way posterior aspect, you need to localize two definite openings here. One is the Vidian and the other one is the V2. So what you can see right here, that's the medial pterygoid plate, that's the lateral pterygoid, that's the greater wing of sphenoid all the way along. That's the pterygoid wedge you can see. So the pterygoid wedge is not pneumatized at all here. That's the marrow fat you can see in the bone. That's the bone marrow you can see in the pterygoid wedge. So what you can see over here is that is the Vidian canal. You can see the Vidian canal here, and that's the V2. So that's the V2. That's the V2 foramen rotundum, that is, and that is the Vidian canal. And you can see the same on the left side. That's the V2 here. That's the V2 here. That's the somewhat not that prominent Vidian canal, I would say. So yeah, so that is V2 and the Vidian here. So that is also you need to carefully observe. So the moment you start seeing the V2, any bone above the V2 is basically the maxillary strut, because this maxillary strut is the bone that is going to definitely separate the cavernous sinus, the superior orbital fissure contents from the V2. So as we go behind, that is the orbital apex, as I mentioned. That was the orbit. As we go behind, that's the orbital apex. So that is basically the superior orbital fissure. The moment you start seeing V2, which is here, here in this case, the V2 is kind of very posterior, somewhat. That's the V2 there. And the moment you start seeing the V2, exactly superior to that should be the superior orbital fissure, and exactly behind will be the cavernous sinus. This is the clivus bone here. So that is how you detect the bony anatomy here. So there is no pneumatization of the there is no lateral recess to the pterygoid wedge over here. So more the lateralization, more the pneumatization, more the presence of lateral recess of sphenoid, more will be the distance between the Vidian and the V2. As you can see over here, there's no pneumatization at all, or there's no presence of lateral recess here at all. And as a result of which, you can see there's no much space between the Vidian and the V2. If there had been a huge lateral recess or a lot of pneumatization of the pterygoid wedge, this V2 would have been here and the Vidian would have been here, way apart from each other. But as you can see, there's no pneumatization, hardly any pneumatization at all. And as a result, the two canals are kind of close to each other. That is a basic anatomy which you can see on the CT scan. So I think I've covered up the basic anatomy. One thing was left, which was a cribriform plate. So yeah, so this one point you need to remember thoroughly, that the presence or the initiation of the cribriform plate is always and always behind the posterior wall of the frontal sinus. The cribriform plate will always be seen posterior only to the posterior wall of the frontal sinus. It will never appear anterior to the posterior wall of the frontal sinus. So whenever you're operating on skull base and whenever you're doing a transcribriform approach, in cases of olfactory neuroblastoma or olfactory groove meningioma, if you're deciding to go endonasally rather than the transcranial method, you need to do a draft on both sides. You need to do a draft 3 on both sides, where you have to completely expose the frontal throughout, and then you need to localize the posterior wall of the frontal sinus. Now exactly behind that posterior wall of the frontal sinus will be your first olfactory neuron. That olfactory neuron indicates the presence of the cribriform plate. That will be your anterior margin. Okay. From that point onwards, you need to drill on the cribriform if you're going transcribriform. And if you're doing a drafts, that olfactory neuron will be a posterior boundary beyond which you should not be going. So all these basic points you need to keep in your mind to have a successful skull-base neurosurgery and to avoid any kind of neurovascular damage inside. So when you see the posterior wall, now this was the frontal sinus, right? That's the frontal sinus. As we keep on going behind, that's the frontal recess, and this is the maxillary sinus, you can see right there. But still you can see a small supraorbital cell over here. So whenever you see the patient's maxillary sinus and at the same time you start seeing a structure similar in looks with the frontal sinus, then that should be a supraorbital cell. So this patient has a very small supraorbital cell over here, hardly on the left side. So behind that, or at that level, behind the posterior wall of the sinus, of the frontal sinus, you can start seeing the crista galli over here. So that's the crista galli over here, and then this is a cribriform plate down there, the medial and the lateral lamella. So that's the crista galli, that's the medial and that's the lateral lamella of the cribriform. So this is basically Kiro's classification depending on what the depth of the olfactory fossa is basically. So it is categorized in 3 parts. It is 1 to 4, 5 to 7, 8 to 16 mm basically, 1, 2 and 3 respectively. The deeper the olfactory fossa, the higher the chances of skull base injury when doing ethmoidectomies, preferably the anterior ethmoidectomies. So all these points you should be having in mind. So now, after having gone through all these basics from the skull base and the neurosurgical point of view, now I'm going to shift on to the surgical video where I'll be showing you all the basic points of the surgical anatomy.
So this is the patient's right side nasal cavity, and I'll show you the anatomy in the most simplest way. So I'm taking a 0-degree endoscope going along the nasal floor. That's the patient's choana. As you can see, it's having some kind of a mucopurulent secretions there. Going up, that's the middle turbinate lower end, and going higher up, you can see a huge opening there. Now, whether this is a sphenoid sinus or the posterior most ethmoid, we need to know. That's high DNS on the patient's right side. So I need to clear all these secretions, and then I'll do a decongestion. Then I'll show the anatomy in a much more better way. So taking suction, gliding along the nasal floor along with a 0-degree endoscope. You can see that's the mucoid and the pus secretion inside the choana from the left side. And you can see a lot of slimy mucoid layer of secretions, and that's a huge opening. So that's ringus lactate I'm giving for wash, which I'm suctioning right now. That's a huge opening back there. So this could be either a sphenoid sinus or a very highly pneumatized posterior ethmoid extending beyond the anterior border of sphenoid sinus. Now, this is the procedure of decongestion. The most common solution to be used for decongestion is the ringus lactate or normal saline. You can take somewhere around 50 cc and dilute that with, you can see there's some mucosal adhesions on the septum and the middle turbinate medial part in the sphenoethmoidal recess right now, and it's kind of oozing a little capillary blood. So I just broke all the adhesions there. So the solution is 2 or 3 ampules of pure plain adrenaline diluted with 50 cc of ringus lactate or normal saline, and you can see I'm using that solution soaked uh, the net cell soaked with this solution, and I'm keeping multiple pieces at different locations. Now the usual locations where the decongestion should take place is, the very first is along the nasal floor in the inferior meatus, which is the inferior surface of the inferior turbinate, so that it decongests and opens up the nasal floor quite better. Then the second place of decongestion is the middle meatus, which is lateral to the middle turbinate. Then the third place of decongestion is the sphenoethmoidal recess, which is medial to the middle turbinate in the anterior and the posterior aspect, in the upper and the lower half as well. So this makes sure that there's a good amount of decongestion. Now what you can see right now, this is post decongestion, and you can see there's some kind of oozing from that mucosal adhesion which I tried to open up, which is present in the superior part of the sphenoethmoidal recess. So that's quite okay. The patient's heart rate was initially high, tachycardic. So we asked the anesthetist to keep the heart rate down at around 60-65 towards bradycardia. So you can see I'm using a neuropathy right now, and I'm gliding it along the septum and along the medial surface of the middle turbinate. This is basically, I'm putting it in the sphenoethmoidal recess, and I'm going to decongest the area of the opening of the sphenoid sinus. That's the uncinate you can see on the 9 o'clock right now of your screen, and I'm trying to glide this. That's the middle turbinate. You can see I'm lateralizing, little bit of suctioning and pressurizing on the net cell. You can see there's mucosal adhesions on the posterior aspect as well, and you can see there's a huge opening there, which I can see just breaking all those adhesions up there. Now whether or not this is sphenoid sinus or the huge posterior ethmoidal pneumatization, we need to confirm for sure. So what I'm going to do is right now take a FREERS, lateralize the middle turbinate. That's the superior turbinate there, and that's the huge opening. Now this could be either a Onodi cell or a highly pneumatized posterior ethmoid. So what I'm going to do is, see, my FREERS is actually going through and through inside. Where my FREERS is right now is now in the sphenoid sinus. You can see I can go to and fro. So that's the actual natural ostium of sphenoid, and not the huge opening which we could see earlier. So that could be a Nori cell or highly pneumatized posterior ethmoids. Do not consider that as sphenoid sinus, otherwise you'll end up injuring the skull base. So what you can see, that is skull base up there, not the sphenoid. So I'm lateralizing the superior and the middle turbinate. So I'm going to poke this suction 1.5 centimeters above the bony border of the superior choana. the superior bony border. Now you can see I'm going to pierce it and I'm going to widen the sphenoid sinus ostium, and what you can see, it's pus oozing out. So we could see on the CT scan that there's some collection in the patient's sphenoid. And what we have here, see, I've packed the superior lateral pneumatization of the sphenoid or the posterior ethmoid with a neuropathy. I've taken it out. You can see that's the sphenoid sinus opening in a very narrow area. So this is how easily you can miss the natural sphenoid ostia and accidentally enter the skull base through the Unodi cell. You can see I'm trying to widen up the sphenoid sinus ostia right now. You can see it's thick pus which is oozing out, and you can see the amount of edema on the surrounding mucosa. You can see I'm lateralizing the middle turbinate and the superior turbinate. That entire area superior laterally is the Unodi cell and the excess pneumatization of the posterior ethmoid. So you can see a bony chip exactly on the sphenoid sinus opening, and the mucosa is quite edematous. So this is going to have a little bit of capillary ooze. Nothing to worry about. If you have a debrider, make sure you use a debrider here. You can see that's the debrider with 0 rad. So I'm just trying to trim that posterior edge of the superior turbinate and the sphenoid sinus ostial mucosa. So very gently, you can see that's the skull base up there. Don't ever try to poke any instrument through and through the bone in the skull base, otherwise you're going to end up having a CSF leak or at least a meningoencephalocele. So very gently, as you can see, I'm trying to reduce or debride that edematous mucosa. So I'm within the sphenoid sinus right now. That's a huge bony chip attached to the sphenoid sinus mucosa. So you can see I'm just trimming off the edematous mucosa in the superior aspect of the sphenoid sinus. But I'm going to keep the mucosa intact. I'm not going to strip off the mucosa. I'm just going to trim the edematous part of it. There's a huge bony chip. You can see it's directed inwards. So make sure you just take a ball probe and take it out instead of using a straight forceps. So this is how you can use a ball probe. Go facing downwards and go behind that bony chip and just pull it towards your side, towards the outside part. This is how you can easily remove that chip. So if you had used a straight forceps, Blakesley forceps, you would be pushing the bony chip further inside. Or you can use an upward forceps facing downwards to hold on to that bony chip. So you can see after removing that bony chip, we should be able to see the sphenoid sinus much more clearly right now. That's the sphenoid sinus proper, but then you can see a very boggy mucosa inside. So I'm going to debride that mucosa, which is excess, and keep the actual mucosa. You can see that's the actual mucosa of the sphenoid sinus. You can see I'm holding the mucosa, the mucosa of the sphenoid sinus. You can see the actual bare bone in the superior half, and you can see the edematous mucosa of the sphenoid sinus in the lower half. So this is a typical cobblestone appearance of the mucosa, and you can see some deficient bone on your 3 o'clock right now. That is the intersphenoidal septa between the right and the left sinus. So you can see that's the healthy bone up there, and that's the Unodi cell probably. Somewhere there is the skull base up there at my suction, and somewhere in the middle should be the optic nerve. So this medial approach is the usual approach which is used by the skull base and the neurosurgeons to operate on a pituitary tumor, sella, suprasellar, or any skull base tumor in the midline. So this is how they approach the sella. See, that's the mucosa attached, and that's the raw bone up there. The bone looks completely healthy, and that's the Unodi cell, and that's the optic nerve where my suction is exactly right now. And that's the skull base above with the posterior ethmoids. That's the bony bulge, and where my suction is right now is the orbit, posterior most part. That's the optic tubercle, I suppose, where my suction is right now. And that's the skull base above. That's the posterior ethmoidal skull base. You can see some bluish tinge there. That's the posterior most part of the orbit. That's the orbital apex. So we've completely opened up the posterior ethmoids. We've completely opened the sphenoid sinus. That's the choana down there. 1.5 centimeters above the superior bony border of choana. So you can see that's the Unodi with the optic nerve. That's the posterior most part of the orbit where my suction is with the lamina. That's the optic right there. And that's the optic tubercle. And above that is the skull base. That's the optic nerve. You can see a very slight bulge of the optic nerve down there. That's the optic tubercle there. So basically, optic tubercle is the junction of the posterior ethmoids and the anterior wall of sphenoid. That's the optic nerve. You can see a very slight bulge of the bony optic canal. So that's the level of the optic nerve. Now you can see much clearly a very slight bulge of the optic nerve on the right side. That's the optic nerve where my suction is pointing out right now, the horizontal structure. That's the crest between the onodi and the actual sphenoid below. So onodi is basically superior lateral. So had he opened up the huge opening where my suction is right now, thinking that that is sphenoid, you would have definitely injured the optic nerve, or at least you would have caused CSF leak. That's a huge crest in the bone in the midline. And you can see that's the deficient bone intersphenoidal septa on your 3 o'clock right now because of the excess pus pressure inside. So I'm going to leave the mucosa like that. See, what I'm doing right now, I'm using a curved suction, and I can actually see the patient's left sphenoid right now. The entire intersphenoidal septa is damaged because of the infection inside, and I can actually see a glimpse of the left side sphenoid sinus. So this is the same curved suction. I'm facing downwards. I'm going to show you the depth of the sphenoid. So that is the depth or the floor of the sphenoid sinus down there, just above the choana. So yes, where my suction is right now is in the left sphenoid right now, to the opposite side, through that deficient bone. So what I can see on the screen right now is the sphenoid and the onodi and the posterior ethmoids. So next step, I'm going to trim the middle turbinate, keeping the the superior 1/3 intact, and the lower 2/3 I'm going to completely take it off. You can see how polypoidal the posterior part of the middle turbinate has become. This procedure has got two advantages. The very first advantage is that it's going to give me more space to work inside, and the second advantage is that if it is somewhat polypoidal, you can trim that. And also, if you're doing a skull-based case, you can use this middle turbinate as a free fascia graft later on, along with the fascia lata as well. So I've done a lot of skull-based surgeries where I've used the middle turbinate free fascia, the mucosa of the middle turbinate, as a free fascia graft. So that's a very good alternative if you do not want to have a fascia lata. So you can see there's a lot of adhesions of the middle turbinate there. I'm going to take it off carefully, somewhat polypoidal, and it looks kind of diseased. It matters. So I'm going to take it off completely. Make sure when you remove that middle turbinate, that's the stump of the middle turbinate, go a little anterior to it and cut that middle turbinate. Do not cut directly on the stump, otherwise you're going to have an arterial spurt of the middle turbinate artery. So this is how I safely remove the middle turbinate without any arterial spurt. And later on, you can coagulate the stump, completely char it with the bipolar, so that there's no post-op bleeding, right? That's the stump right there. Make sure you cauterize that with the bipolar. See, that's the middle turbinate, leftover part. The anterior ethmoids, I'm lateralizing it. And I'm going to take off the middle turbinate. That's the sphenoid sinus, you can see. And that's the onodi cell, along with the optic. And that's the posterior most of the orbit. See, that's the optic nerve. And that's the sphenoid down there. So this is how you carefully open the sphenoid with proper anatomical landmarks, and this is how you can prevent any kind of neurovascular injury to the skull base. See, that's a huge area we've exposed for the skull base and the posterior orbit. That's the skull base. So that's the skull base above. That's the optic nerve. So I'm going to keep showing you all the anatomy. That's the optic nerve horizontally. See, this is how the optic nerve travels in the midsection of the orbit. That's the posterior most part of the orbit with the orbital apexes along with the annulus of Zinn. So this is how the optic nerve travels at the midsection and then follows behind. That's the optic tubercle. You can see that's the thick bone. So basically where my suction is right now, the vertical bony part, you can see that's the optic tubercle, a thick bone which is present between the posterior ethmoid and the anterior wall of sphenoid on the lateral aspect. See, that is how the optic nerve is going to travel. That's the posterior most of the orbit. That's the optic tubercle behind where my suction is, and that's the optic nerve. So if you want to do a optic nerve decompression, you have to drill out the optic tubercle. So I've shown this procedure in a lot of my FESS marathon and skull base marathon cases 2023, which you can go and check it out. Each and every procedure I've shown in all those multiple FESS and skull base marathon videos. So you can see very clearly the relationship of the optic nerve and the optic tubercle. That's the optic tubercle right there. And you can see there's a huge crest between the onodi and the sphenoid sinus. So that's the sphenoid sinus below with a normal mucosa up there and a boggy mucosa in the inferior half. So I've kept a lot of pieces of net cell in the sphenoid sinus and the posterior ethmoid. You can see there's a small fontanelle there. That's the posterior fontanelle. That's the uncinate. So if it is behind the uncinate, it's posterior. So go along the superior surface of the inferior turbinate. That's the uncinate process right there. Go behind the uncinate and take your curved suction and just pierce it at the level of the superior surface of the inferior turbinate. This is the most safest and the most fastest method of opening the patient's maxillary sinus. See, glide along the superior surface, just poke inside at the level of the superior surface of the inferior turbinate, move it around up and down, posterior, anterior, make it in a circular fashion, and what you can see is that the huge maxillary sinus opening within 5 seconds. So this is how you open up the patient's maxilla within 5 seconds without causing any kind of orbital injury, any kind of excess vascular ooze. So you can see in front of you, you have the biggest maxillary opening you can think of. But still, I can make it twice the size of what it is right now by removing all that soft tissue around the opening. That's the uncinate. So you can see there's a huge opening of the sinus. Now what I'm going to do is, instead of using a backbiting forceps like we normally do, what I'm going to do is I'm going to take an upwards Blakesley and I'm going to palpate the posterior part of the lacrimal bone. See, that's the lacrimal bone there, and everything behind that is just the uncinate. So I'm going to just pierce it, and then I'm going to halfway twist it clockwise. And you can see what I'm doing right now is the complete vertical uncinectomy without even touching the orbit or the lamina. So this way there is no damage to the orbit, and you can see in 2 seconds, max to max 5 seconds, I've done the vertical uncinectomy. But just one point to remember here is don't go too lateral to damage the lamina. And the second point to remember here is that when you do a vertical and a horizontal uncinectomy, that's also a part of the vertical I'm taking off right now. You can see this huge maxillary opening we have right now. So as I was saying, if you're going to do a vertical uncinectomy, make sure that the lowermost part of the vertical uncinate, the mucosa, is in continuation with the mucosa of the maxillary sinus. So if you are not careful enough and just pull on that, it's going to strip off the mucosa of the maxillary sinus. So make sure I'm taking a through biting forceps. I'm just going to cut this, and I'm going to take off that excess tissue right there. So the more tissue you take off, which is polypoidal, the uncinate, the vertical and the horizontal, the bigger opening you get for maxillary sinus. Now, if it's a case of a severe AFRS, or it's a case of inverted papilloma or any sinonasal tumor in the maxillary sinus, that's the floor of the orbit up there. You can see the floor of the orbit very clearly. So what I'm going to do right now is just debride all that polypoidal tissue surrounding the maxillary ostium to make it even more bigger. So in cases like AFRS, severe AFRS, malignancies, tumors, inverted papillomas, or any huge AC polyp, where you require a huge opening of the maxillary sinus, you can perform this procedure very safely. There's no side effect in the long term. There's no excess crusting for the patient, and there's no excess nitrogen nitrogen oxide retention or carbon dioxide retention in the sinus. There's no damage to the mucociliary action as well. You just make sure you keep the sinus mucosa intact, the mucociliary function intact, and everything's going to be fine. So you can see I'm just using a debrider, taking off the anterior ethmoidal cells and making it even more bigger for the maxillary sinus opening. So you can see exactly superior to the maxillary sinus is a lot of anterior ethmoidal air cells, the bulla ethmoidalis, which is actually attached to the lamina papyracea as well. A lot of surgeons out there Even in cases of severe polyposis, do not remove those anterior ethmoidal cells which are lateral, just close to the lamina papyracea. They do not remove it, and the patient comes back with recurrence of polyposis. You have to make sure that you have to remove those anterior ethmoidal cells along the lamina. Okay, so you can see now the almost the entire skull base is visualized. That's the optic nerve right there. That's the optic nerve, and that's the posterior ethmoidal artery, clearly seen right there. And you can see a lot of polypoidal anterior and posterior ethmoidal cells still remaining there. That's the optic nerve, and that's the posterior ethmoidal artery. So that's the anterior wall of sphenoid, basically. Yep, and that's the posterior ethmoidal artery right there. That's the crest between the sphenoid and the onodi. So you can see that's the optic nerve visualized, the posterior ethmoidal artery visualized, and what I'm trying to remove right now is all those diseased polypoidal anterior ethmoidal air cells in the superior half towards the skull base and the lamina papyracea. So if you don't remove that, the patient is definitely come back with recurrence of polyposis. And also, in cases of orbital decompression, where be mucormycosis, invasive fungal sinusitis, or any orbital tumor or optic nerve decompression, orbital decompression, this step is absolutely necessary. Now, there is still a lot of anterior ethmoidal cells still attached to the lamina. Now, where my instrument is right now, whether that is the lamina or whether that is the anterior ethmoidal cells, you need to confirm that before you go poking inside the lamina. But I still see my assistant is pressing on the patient's right side eyeball right now, but I cannot see any movement happening inside. So I'm safe. My lamina is not breached. Always perform that maneuver. It's called as Stankovic sign. You press on the patient's orbit, and if you see the movement inside, it means the lamina is deficient or dehiscent. See, I'm going to poke on that, and what you can see, it's a huge amount of anterior ethmoidal cells that was still remaining behind, and this is the exact cell I'm talking about that a lot of surgeons out there do not even dare to touch. And this is the main area where the recurrence of polyposis is going to happen in the ethmoidal area. So when you remove that cell, it becomes the entire complete ethmoidectomy. See, now you can see that's the lamina papyracea there, and that is some polypoidal mucosal attachment. You can take it off very safely from the use of a debrider. Make sure you use a debrider. That's the superiormost polypoidal part near the frontal opening, which I'll deal with later with the 70-degree endoscope. So now, in cases of orbital decompression, right from the nasolacrimal duct area to the optic nerve, the entire lamina papyracea should be visualized. So you can see now that's the lamina papyracea, kind of thinned out. There's some ooze from there, which we can control. So we have skull base at 12 o'clock. We have the entire orbit at your 9 o'clock. We have sphenoid at your center. That's the optic. That's the skull base above. That's the optic nerve. Here it travels like this. That's the orbit right there. So it travels, that's the superior and the inferior direction, and that is how the optic nerve travels in the midsection of the orbit. So you can actually trace that towards the skull base. And if you keep tracing the optic nerve, you can trace the optic chiasm in the center and the optic nerve on the opposite side. So now what you can see is a 70-degree endoscope right now facing downwards for the patient's right side. And you can see I'm using a 70-degree endoscope and facing downwards for the patient. See, that is the patient's face, and I'm holding the 70-degree endoscope facing downwards, going in along the superior surface of the inferior turbinate. That's a very important landmark, the inferior turbinate, along the superior surface. And what you can see, the entire maxillary sinus from within. I can actually visualize each and every corner. That's the anterior lateral part. You can see a pus point there at the floor near the molar insertion. That's the anterior lateral. You can see that depression there. At your center is the anterior lateral most part of the sinus, and you can see a glimpse of the floor of the orbit. Now what I'm going to show you right now, you can see a huge blood clot. It is actually moving towards you on the screen right now. You can actually see it's moving. This is what you can see. Actually, you're seeing the mucociliary action live on the screen right now. See how the blood clot is moving towards you? That's the mucociliary clearance of the mucosa within the maxillary sinus. Very brilliantly seen. So that is how the mucociliary clearance of the maxilla takes place. So you can see the entire maxilla just with the help of the 70-degree endoscope right there. So just trying to clear that pus point over there at the floor of the sinus. So you can see there's some soft tissue still left at the lowermost part of the maxillary opening. See, that's the infraorbital nerve where my suction is right now. That's the floor of the orbit where my suction is pointing out right now. So this is a 70-degree endoscope in the patient's right side maxilla, facing downwards in the sinus, and that was the patient's floor. That's the soft tissue I was talking about, still blocking my view of the patient's maxillary sinus. What I'm going to do right now is I'm going to remove all that soft tissue. I'm going to puncture that area very easily. See, like that. I'm going to puncture it, lift it up, and I'm going to take off that excess soft tissue. This could be the horizontal process of the uncinate and the bony part of the maxillary sinus ostium in the inferior region along the nasal floor. So remove that very safely. See, I can also remove that inferior turbinate exactly corresponding to the opening of the maxillary sinus. I can cut the inferior turbinate partially, and I can have an even bigger opening for the patient's maxilla. So all these maneuvers or procedures depend on what the condition of the patient is. Depending on that, you need to follow these procedures and have the maximum opening for the patient's maxillary sinus as much as possible. So I'm going to take off that excess soft tissue just like that, and you can see by removing that, I'm able to visualize the patient's sinus even furthermore. So that is still 70-degree endoscope. See, I can visualize this area far more better now. That's the nasal floor, and that's the sinus just lateral to it. So you can imagine if I remove the inferior turbinate also, cut the inferior turbinate, I can have an even bigger opening for that area. So when the patient comes for a follow-up in the OPD itself, I can just put a normal 0-degree or a 70-degree endoscope and examine the entire maxilla without having the need to go through the external canine fossa or the dentures or the prelacrimal dentures. Nothing of that sort is required here. That's the orbit above, the lamina. So I'm going to shift back to the endoscope. Now this is still the 70-degree endoscope. So I'm just now facing it upwards. Now it was all this time facing downwards. Now the exact 70 is facing upwards. Now I'm going to show you with the help of 70 facing upwards the opposite side of sphenoid sinus through that deficient bone, which we could see earlier. So I'm going to take my 70-degree endoscope facing upwards, go in the sphenoid sinus, turn clockwise, and there you can see that's the patient's left side sphenoid sinus, completely normal, unlike the patient's right sphenoid. So that you could see the patient's left sphenoid with the 70-degree from the patient's right side. So you can do that actually. So you can see I'm giving a wash with Ringer's lactate and budesonide and an antibiotic inside. That's the stump of the middle turbinate. You can cauterize that later. That's the sphenoid sinus with the boggy mucosa. That's the optic nerve onodi. That's the skull base above, and that's the posterior orbit there. There's a huge exposure on the patient's right side. That's the huge maxilla. You can actually see the entire skull base. That's the skull base up there. And I've already examined the posterior ethmoidal artery. That's the skull base above. That's the huge maxillary opening. That's the choana down there. So if a skull base or a neurosurgeon knows the anatomy of the endonasal point of view, they are definitely going to be, very easily going to be able to operate on the skull base and neuro cases. So now this is again 70-degree endoscope facing upwards now, and you can see that's the curved suction, just trying to suction the area. That's the orbit where my suction is right now. That's the floor of the orbit through the sinus seen right now. So this is 70-degree endoscope facing upwards, and it's visualizing everything. And the suction is at a higher level than the endoscope. So you can see that's the skull base above. Now my aim here is to find the patient's frontal sinus. That's the orbit. You can see a huge bulge of the orbit. That's the anterior-most ethmoidal area. That's the area of the Agger nasi basically. Now the very first step is to identify the middle turbinate. You can see that's the middle turbinate. I have kept a hefty amount of the upper 1/3 of the middle turbinate intact just for that to act as a landmark. That is the agonizing cell where my suction is right now, the superior most part of the agonizing. I need to find the frontal sinus opening, which I am not able to see right now. That's the anterior most part of the frontal sinus. So see, the basic principle to identify the frontal sinus here in such a situation is that you need to understand the anatomy. Now, the frontal recess is bounded by two sides. The anterior boundary is by the agonizing and the posterior boundary is by the bulla ethmoidalis, basically. So what I'm trying to remove right now is just the superior anterior wall of the agonizing. I'm just taking off the agonizing cell here. That's the middle turbinate. Go lateral to it. That is the agonizing cell. I'm taking off the agonizing cell, and in no way I'm going to be damaging the patient's anterior ethmoidal artery. I'll tell you how. So first step is to identify the middle turbinate. Always keep the upper 1/3 of the middle turbinate intact. Go lateral to middle turbinate. Find the agonizing cell attached to the middle turbinate superior part along with the uncinate. See, I'm still not able to find any opening of the frontal sinus. What I can see right now is the orbit, the skull base. See, that's the skull base and that's the orbit. The junction of the skull base dura with the peri-orbita is called as the meningo-orbital fold. The MOF, meningo-orbital fold. When you go transorbitally, you open the skull base from the orbit, you are able to see the dura in connection to the peri-orbita, and that is called as the meningo-orbital fold. Remember that. So you can see the entire skull base, the entire orbit visualized right in front of you. This is basically a full house FESS. Now, I cannot see any opening right now. Neither can you, right? So how to visualize the patient's frontal sinus very easily, I'll show you right now. I'm just trying to suction out the anatomy for you. That's the entire skull base right in front of you. Now, first step, identify the middle turbinate, upper 1/3, go lateral to it, take off the agonizing cell, and now, what you can see right now, that is the uppermost part of the agonizing cell. Just lateral to middle turbinate, that is the medial boundary of the agonizing, will be attached to middle turbinate, which is always also in continuation with the uppermost of the uncinate. See, that's the middle turbinate. Go along the lateral surface of the middle turbinate, which is basically the medial wall of the agonizing. Go between the two. See, I went between the two structures, and you can see some escape of air bubbles. That is how the frontal sinus recess will be accessed. See, between the two. That is the most simplest technique. This is how you can prevent any inadvertent injury to the skull base. See, my suction will go. That's the agonizing roof. It's still there. The agonizing cell is still there. Now, how to uncap that? So you can see I'll take my suction now, and I'll go between the middle turbinate and the agonizing medial wall. You can see that the dome, this is the agonizing at your 12 o'clock, like a dome shape covering the frontal sinus opening. So once I take my suction and enter between the medial wall of the agonizing and the lateral wall of middle turbinate. So that's the middle turbinate. Never go medial to middle turbinate, otherwise you'll injure the cribriform. Go lateral to middle turbinate, and see, I'm going to break that cell. That is the agonizing cell. I'm going to break it now with the suction itself. See that? That is the uncapping of the roof of the agonizing. Exactly behind that will be the frontal recess and superiorly the frontal sinus. See how easy that was without causing any ooze or bleeding, excess bleeding or damage to any critical structures inside. So I just uncapped the agonizing. I'm going to go with a 70-degree endoscope, take away all that bony cell of the agonizing now. So this is how the Kuhn's type 1 and the Kuhn's type 2 cells also get formed above the agonizing and block the frontal sinus completely. See, I've uncapped the agonizing. I'm taking all those bony chips out. And then I'm going to suction it, clear it. You can also debride that with a RAD 40 or a RAD 60. And there you can see that's the frontal sinus for you guys. See, the simplest way was to just uncap and use the help of the middle terminum. Now that's the anterior ethmoidal artery. You can see that very clearly. That's the anterior ethmoidal artery, and that's the bulla ethmoidalis superior part. Behind the bulla ethmoidalis superior part, you can see that's the anterior ethmoidal artery right there. So that's the clear indication that that's the anterior ethmoidal artery. That's the posterior ethmoidal artery right there, which we could see earlier. That's the entire skull base for you, and that's the sphenoid behind that's the optic nerve right there behind. So we visualize that's the anterior ethmoidal artery very clearly. So we visualize the anterior ethmoidal artery, posterior ethmoidal artery. That's the supraorbital cell right there. So that huge cell where my suction is right now is the supraorbital cell. That's the supraorbital cell. So from anterior to posterior, the most anterior structure will be the frontal sinus, which we have just opened up. That's the frontal sinus up there with the suction. Exactly behind the frontal sinus, which is behind the posterior wall of the frontal sinus, will be the supraorbital cell or the supraorbital recess. See, that's the frontal sinus within, and you can see that small mild bulge of the frontal lobe on the posterior wall right there. So exactly behind the frontal sinus will be your supraorbital cell, which you can see right now very clearly. That's the frontal anteriorly. Wait, I'll show you again. See, that's the frontal opening anteriorly, very clearly seen, and that's the supraorbital recess behind, very clearly seen. Always and always, this is the anatomy. So if there is no supraorbital cell, sometimes there will be fovea ethmoidalis, and exactly behind. See, what I'm trying to do right now is to take off that partition bone between the frontal sinus and the supraorbital cell, just to make it one common cavity. You can do that. You can use an angle burr, 15-degree angle burr, diamond burr, coarse diamond burr, and drill that bone off. Or you can use a debrider drill and take off that bone. So once you do that, it makes a common opening for both the frontal and the supraorbital cell. And you can see exactly behind the supraorbital cell, there is the artery right there. That's a small attachment of the bulla ethmoidalis, and exactly behind the bulla ethmoidalis is your anterior ethmoidal artery. So that intact bulla technique, which you know of, basically protects the anterior ethmoidal artery, but I've never used the intact bulla technique in my 8 to 9 years of my career as a skull base surgeon. So I never used an intact bulla technique. What technique you saw right now, I always use this technique, which is the most safest also. And you can see the anterior ethmoidal artery is so far away from the actual frontal sinus, but very close to the supraorbital cell. So you need to know the difference between the frontal sinus, the supraorbital cell, the fovea ethmoidalis, and the bulla ethmoidalis and the anterior ethmoidal artery location. Sometimes, very rarely, the anterior ethmoidal artery may be just lying behind the frontal sinus. So in that situation, you need to go through the CT scan very thoroughly. So you can see that is how you open up the patient's frontal sinus very clearly. The patient's supraorbital cell, the anterior, posterior ethmoidal artery, the optic nerve, and all the basic anatomy of the orbit. So if a neurosurgeon is watching this video, the advantage of opening up the patient's maxillary sinus in such a huge extent is that far laterally and superiorly in behind the maxillary sinus is the pterygopalatine fossa and the infratemporal fossa. The infratemporal fossa hosts the lateral pterygoid muscles, basically temporalis muscles, the lateral pterygoid muscles. If you dissect them, you get the foramen ovale, where the mandibular nerve, the V3 is clearly visible. Exactly behind that will be the middle meningeal artery. Exactly behind that will be the parapharyngeal ICA, and all that will be the greater wing of sphenoid basically. So if you drill on the greater wing of sphenoid exactly behind the maxillary sinus, a little superior laterally, you will have a direct access to V2 as well through the PPF and the huge temporal lobe of brain, the base of it. You'll have a direct access through your patient's maxillary sinus the way I opened up right now. So you can access the patient's temporal lobe through that maxillary opening in the ITF and the PPF area. And with the structure which you can see in the frontal, you can repair any frontal lobe tumor, frontal CSF leak. You can perform a drafts procedure, which everything I've shown in my skull base and my FESS marathon videos. You can just go and have a look and see all those surgeries where I've performed a lot of drafts, skull base procedures, CSF leaks, tumors, temporal lobe tumors, clivus tumors, clivus diseases, osteomyelitis, everything I've shown in my skull base videos. A good hefty amount of videos you can see in that marathon series. So I hope you liked the video. Any doubts, you can just post your comments in the section below. I'll be happy to reply to all your doubts. Thank you so much.